amazing.
Roger, you need to open up another flow lab.
So, are there any questions? Shall I start? So, just to summarize, that means that sustained MRD negativity may take us to treatment-free period for patients?
Yeah, maybe I can start and please others chip in. I think consistently with the combination of agents that we're using in the upfront setting, we're getting more patients to MRD negativity, and we're starting to observe with longer duration MRD testing using bone marrow approaches that close to a third, if not a quarter of patients are sustained MRD negative. And I think the real question is, what is continuing treatment really doing to these patients who are in a sustained MRD negative? And obviously, we end up opening up treatments for smoldering myeloma. We need to make space for some patients to leave the treatment pathway so that we can make space for other. So I think there's going to be compelling cases being made with some of the trials that we're doing. And I think patients would be very appreciative of us considering stopping treatment early.
And will we have ability to intensify treatment if MRD was consistently positive?
Well, not in our approved pathways at the moment, but obviously that's what ongoing trials are looking at, and I think that is probably the direction of travel. At the moment, we have a very, transplant eligible, not transplant eligible, but I think what we're looking to move towards and what MRD would help is personalisation of treatment.
Yep. Any questions?
I conceptually have less problem with intensifying treatment in the context of a positive result than abbreviating treatment in people with a negative result. So I think particularly in so for lenalidomide maintenance, for instance, we know that is a very effective intervention. We don't really know from basic clinical data what the optimum duration of treatment for that. Obviously, Charlotte's data from before suggested it was actually quite a long time. And the people who benefited the most in myeloma 11 were those who were actually MRD negative and receiving maintenance. So it's not a straightforward process. I think if you're thinking about abbreviating stopping treatment, then you think you really do need to be doing things by several methods and not one. And I think it's much easier to think about different therapeutic strategies in people who've got a positive result, particularly when you've got a level of disease that's relatively high, because you're pretty sure what their outcome is going to be.
Can I just ask a question? Just sorry, very quickly before we go to the floor. But in terms of sort of industry colleagues when they're making submissions in the future based on these trials for fixed duration treatment or for stopping treatment. Presumably these testing for MRD, these costs are going to have to be built into that sort of submission that they make, because you're using that result to change your management, which I'm not aware that currently is maybe part of submissions. So that costing will have to be included as part of the drug costs, etc., which I suppose is why we need to continue to use clinical trials, because we're getting access to that.
Yeah, if I were to quickly respond to that, I think the first test is going to be applied when DARA-LEN maintenance does get approved. So once that approval comes through, and if that's taken to NICE, then you can only cost up DARA for 24 months if you have an MRD testing in place in the UK for all the centres. So that will be conditional on that, which means every centre needs to have an access to doing the MRD test.
Will you know which one?
Well, I think potentially if the clonoSEQ method or its generic version gets into the test directory will be an option, and in those who can do it by flow will be an option. I think NICE will probably say something along the lines of, as long as you have a test which gets to a certain threshold sensitivity, then you could probably apply either of those. And but it'd be nice to have the ability to do either of those tests.
Thanks. Can I ask, in other malignancies like ALL and AML, we've been using MRD to guide treatment and prognosticate for a while now, and there's interventions we can do when people either become MRD positive or remain MRD positive. Why do you think we're not there with myeloma just yet? I mean, clearly there's work going on, but why do you think it's proven more difficult, or you know?
I'm not sure, actually. I think there's a cultural element to this, actually. I think people who treat acute leukemia are seem more willing to use the data. I don't think the evidence is any different. The strength of the evidence is any different in AML than it is in myeloma, but we just seem to do things differently. I don't know why that is. I guess
There is a pace difference with acute leukemia as well, though. If you've got MRD resurgence in your marrow, you're going to see a relapse very quickly. Whereas we know that if you have MRD resurgence in the marrow in myeloma, that precedes a clinical relapse by potentially years. So there is a clinical difference as well.
And there's a numbers difference. If you're thinking about acute leukemias, where it's, they either get better or they don't. So it's usually reasonably time limited versus years and years and years of myeloma accumulating thousands of patients. Just from a pure cost perspective, you can imagine it would be hard to get it over that line.
We hope to get that cost offset by the savings in the treatment.
Absolutely, but I think that's also one of, just looking at the genomics, this is a real problem. So any additional testing we do in genomics is going to cost more money because it's more testing. Unless we can come up with the 1P test, which does everything and replaces everything else, it's always going to cost more money, which means its budget just goes up and up and up, which isn't happening. And although you're saving thousands, tens of thousands of pounds in unnecessary treatments, potentially, that's a totally different budget in a completely different silo that doesn't get taken into account when you're trying to fund a new expensive genomic test. So there needs to be a much better overarching approach to, yes, we're putting an expensive test in, but the health economics is that we're saving money here. And that just, there's no capacity for that to happen at the moment, which we bring up time and time again because it's just so frustrating.
Yeah. And it's very complex modelling because it's not just the drug costs, there's the clinic visit costs, the other blood tests associated with it, the clinician time, so...
There's a question on the floor.
Yeah, sorry, with regards to MRD testing and AML, for instance, both myself and Qui put up our hands simultaneously to make the same point, is that AML is potentially curable with treatments which can be initiated on the basis of MRD testing, whereas that does not apply to multiple myeloma as of now. The other question I wanted to ask independently was, what does the panel interpret the fact that MRD negativity is dependent on the treatment received to get there, in that the addition of monoclonal antibody MRD negativity had more favourable PFS than BRD MRD negativity? I mean, the simplest explanation would be that it's just the extent of MRD negativity rather than a single plus minus. Is that everybody?
Yeah. So I think on the whole, when you and this is very old data, and I'm not sure people tend to look at this anymore, but if you, regardless of treatment, and if you look at the outcome according to levels of disease, then the outcome is determined by your level of disease and not the treatment that you got to receive it. And where there's a difference, there can be difference. So you can't extrapolate the difference in MRD positive from between treatment A and treatment B may just account for levels of disease. And similarly, if you're the difference between treatment A and treatment B for MRD negatives may well just mean that your level of depletion, which by definition is below the threshold of your assay, is deeper with treatment A versus treatment B. So most historical data suggests that the outcome is determined by your level of disease and not how you got there.
Can I respond to the other point? I think the depth of response is one reason why we're seeing a difference. We're also possibly seeing a difference because of the immunomodulation that we get from these monoclonal antibodies. And particularly what is striking in some of the early data that we see with belamaf, is the fact that you're almost kind of resetting the kind of immune microenvironment. You're not just killing the cells with the BCMA targeting, but you're kind of resetting the immune signals in the microenvironment. That's why you're getting increased duration of response, even with giving 8-12 weekly, belamaf and sustaining MRD negativity in these patients. So I think there is the other element around change in immune microenvironment.
And it's impacted by ongoing therapy. So a lot of the data relates to MRD at the end of therapy. But we're now looking at MRD that's in the middle of therapy and people are carrying on therapy.
Okay.
There's a question on the floor there?
Yeah. Yeah, I mean, MRD negativity clearly confers prognostic benefit. Is there any data the kinetics of getting there influences outcome?
It's how soon you get it.
I don't think there's data there because no one's chosen to look at it in that way, and that we always choose the time point for assessing it in the context of what the schedule looks like. So, we've always historically done it at day 100 post ASET. That's an historical quirk, and certainly all the MRD testing now is predicated on obvious breaks in therapy.
Hi, a few points. As to the last question, I think the kinetics of achieving MRD negativity really reflect the efficacy of the regimen you're receiving. And so the very effective 4-drug regimens, maybe the bispecific antibodies, you get to MRD negativity faster, whereas the slower regimens like DRD, you get to MRD negativity with a rather slower tempo. And that's probably all it really reflects. But I wanted to come back to the question of, I wanted to pick up Roger on his reluctance to stop treatment in the face of MRD negativity and sustain MRD negativity. So today the dialogue is moving on to talking about whether you could do that with a plan for dealing with MRD resurgence. So people are talking about fixed duration treatment and then you stop MRD negative if you're MRD negative, but with the option to restart the same treatment if you become MRD positive or if you have resurgence. What do you think about the biological and clinical rationale of doing that? Do you think that makes sense, or do you think once the disease has escaped, you should be using a different regimen?
I think the first part of your question is a bit easier for me to answer. The second part is quite difficult. I think the problem for me is that we're making profound clinical decisions at the point where the assay is at its weakest. So even with clonoSEQ, the CV at the limit of detection is 50 to 75%. So if you look at the clonoSEQ product literature, you will see that the CV of the assay, when you're down at that 10 to the minus 5 and 6, is around 50%. And we know that, so whenever you compare methods, people always produce really nice comparative curves, and they get nice R-square values of 0.9, and that's because they front-load it with a whole load of high-level tests where you're going to definitely have a lot of correlation. But as soon as you're going to be making a definitive yes or no treatment based on an assay where you know it might not be right, and you could get a different answer in a different lab, and you could get a different answer in the same lab on a different day.
Cool. No, good point. Perhaps it's the dynamics.
And whenever you look at any MRD studies and you look at two methods, so there's always discrepancies, and this is regardless of whether you look. So whether you're looking at mass spec with flow, you're looking at flow with NGS, you're looking with flow with PET scanning, you will see that there will be patients that are negative with both and positive with both, and they fall out quite nicely. But there will be there will always be discrepancies. So ones that are positive with one and negative with another, and they're the ones that will have an intermediate outcome. So I think if you're thinking about, for me, if you're thinking about stopping something that historically you think has actually been really very effective, I think you need to be sure that of what you're doing, because I think a single MRD test, whether that's a flow test or the clonoSEQ test, at that level, if you're looking at 10 to the minus 5 or 10 to the minus 6, is where the assay is at its weakest.
Take your point. Perhaps kinetics of rise is important, but I'll let Matt.
Yeah, I think we'll probably have to stop there. Maybe more discussion over coffee, but yeah. Oh, Matt, do you want very quickly, but.
Just very quick comment and question. So in terms of the kinetics, I think the genetics is really important because we all see the high-risk patients who have a really rapid response, and therefore, you know, I think you have to be very careful not to assume that a rapid response is associated with a good outlook. So I think it's a combination of genetics and response. But the question for Hannah, you know, coming back to what you started with about the comparison between some different techniques is, and then Roger's comment about single point of analysis. If we were to be in a position in the years ahead of moving towards sequential MRD testing using a serological technique rather than a bone marrow technique, we might be able to get the best of both worlds and have persistent, you know, 6 monthly of continuous MRD, 12 months, 24 months, whatever defines that. And I think obviously the importance of that is actually generating the data. My own view is we're far too early to be making treatment decisions on the basis of MRD, but we should be generating the data to help us make those decisions in 5 years' time.
Thank you very much. So if everybody can join me in thanking our speakers, that is our yeah, we'll reconvene at 11:55 if that's okay after coffee. And just to remind everybody who's here and online that the talks are recorded and available on the UKMS website in the member zone.
Like the quality of the sample if you're using clonoSEQ.